So LATITUDE specifically, I think, changes the standard of care yet again, because adding basically is as you know, is a 1,000-patient trial roughly, where patients were randomized, castration-sensitive metastatic patients were randomized to either ADT plus placebo or ADT plus oral therapy with abiraterone and prednisone. Primary endpoint of that trial was actually survival, and the hazard ratio for that survival was actually in the was 0.63, meaning almost a 37% risk reduction in mortality if you get abiraterone at front with ADT. Now, the uniqueness about this trial is that if you look at the patient population of LATITUDE, it really, to some extent, mimics what we actually have seen in the charted data, which is basically men with more than 3 bone lesions, visceral disease, and Gleason scores of 8 or greater, which is different, to what we have seen with charted. For Karim's data, which is the LATITUDE, we look at 2 out of those 3 risk factors for inclusion for the definition for high volume disease, which is again different to what we saw for charted. Now, if you look at the trials, and look at the makeup of patients with Gleason score of 8 or higher in charted, roughly is the same number of patients that we have seen in LATITUDE. So to us, I think the patient population is roughly the same. So I don't think there's a big difference in the makeup of those patients. And I think the important part is adding Abby at front not only makes people live longer, but also reduces the risk of relapse, median actually almost by double, 14 months of ADT alone against almost 33 months with ADT and abiraterone acetate. At the addition of abiraterone also is able to actually delay progression, skeletal related events, PSA declines, and time to chemotherapy as well. So it's a pretty powerful trial, and I think that data certainly will change how we practice now.